This is the IACH, International Academy for Clinical Hematology, broadcasting live from France and the UK. I'm Mohamed Moti from the Sorbonne University and Saint Antoine Hospital in Paris, in France. And it is my great pleasure and honor to moderate this special webinar dedicated to nursing care and frailty in multiple myeloma. And to discuss this important topic, my panelists and guests today are really top experts and with great experience in this field, namely Dr. Orla Mccourt, who is a clinical specialist physiotherapist in myeloma at University College London Hospital NHS Foundation. And in her doctoral research, she focused on the feasibility of embedding exercise within clinical pathways in patients with blood cancers. The second panelist, and they are by alphabetical order, by the way, is Audrey Robb, who is an advanced myeloma clinical nurse specialist for North Glasgow in Scotland, and will be in Scotland in April for the EBMT meeting, by the way. So she is based at the Beatson Oncology Center in Glasgow, and she also covers outreach myeloma clinics across North Glasgow. And she's been involved in this field for more than 30 years, despite her very young age. And last but not least, it is Emma Williams, who already contributed to these webinars. She is currently a senior hematology research nurse manager in the University Hospital of Wales. And she has an extensive experience when it comes to clinical research in multiple myeloma. And just for the sake of introduction, I would like to emphasize and just explain why we chose this topic of frailty as a priority for these webinars. Well, obviously, I think everybody is well aware that the median age actually of a myeloma patient in Western countries is around 70 to 72-year-old. So this, although many people would think you're still young at age 70, still it has become an advanced age. And unfortunately, age comes with comorbidities. Age comes with frailty because the machine gets a little bit tired with time. Let's say it like this. So, and this is why the management of these patients will become more and more, in my opinion, personalized. And this is crucial because in this field, we've seen some tremendous, amazing advances. I remember at medical school, I've been taught that the treatment standard of care was melphalan prednisone, MP, and that would give you maybe 12 months, 18 months survival. 2007, we had the publication of a new standard of care, MPT, melphalan prednisone thalidomide. 2014, new standard of care, RD, lenalidomide dexamethasone. More recently, 2019, standard of care, daratumumab lenalidomide dexamethasone. And very recently, you may have seen a very exciting press release about the results of the IMROSE trial, which is a randomized phase 3 trial, which tested actually VRD bortezomib lenalidomide dexamethasone as a control arm versus isatuximab VRD. Obviously, I don't know the results. They haven't been released yet. But actually, if I read between the lines, the press release, we are definitely having now another breakthrough when it comes to managing elderly multiple myeloma patient with a quadruplet combination like isatuximab VOD. So that was really the background for looking into this frailty issue. So my first question, and please don't hesitate to ask questions to each other. And this is a live webinar, highly interactive. So I would encourage you guys to post your questions and comments, and I'll do my best to share them with our panelists today. So my first question is, how do we define frailty? And when I ask this question, Audrey, Emma, Orla, it's not about, the fantastic magic superb scales we have, and you can spend hours doing this. Rather, from a pragmatic, practical point of view in your practice. I don't know who wants to start. Shall I designate a volunteer by alphabetical order? Audrey, you would like to jump in?
I mean, I think, frailty scores and things obviously have their place, although it's actually extremely difficult to put those into practice in a clinical setting. But I think certainly, experience and kind of getting to know your patients is really at the root of it, and knowing what their starting point is at first diagnosis and before they start any treatment, and being able to kind of see, as you alluded to, what their capacity is through treatment and whether that changes in any way. And really that's probably, our practice as clinicians at the moment. We don't formally do frailty scores just now, although I know it is a big thing and has obviously been involved in or included in quite a lot of research recently. But as I say, putting that into clinical practice is extremely difficult. So it's very much, sight and seen and using your eyes, listening to patients, actually spending a bit of time with them as opposed to just very quick clinical visits. And that's certainly what we try to do, is from the nursing team point of view, to kind of be that backup to the clinical decisions that are made by the doctors in clinic. Yep.
Thank you, Audrey. Orla, can I ask you, from a physiotherapist perspective, how do you define or how do you detect frailty?
Yeah, so I think from my professional context, I look very much at function and very much all the things that Audrey just said. What are people able to do in their day-to-day life? What have they been doing sort of up until, whether it's a diagnosis or recently or in the last sort of few months of time? Because frailty can be quite dynamic, and some things can we talk about vulnerability to sort of being knocked off a stage of sort of function or ability to cope, and often that can be sudden or it can be gradual. So I think it's really important to know what people were up to sort of recently, how they're living their life right now, and so my focus is very much generally on function, and that can be function as in day-to-day activities of daily living, how they're managing those, but also exercise and physical activity in terms of do they exercise? Have they been a historical exerciser? So it's often good to know what people over their life course were doing, because more and more we do see more people who've generally been inactive their whole life, and that can generally predispose people to being more likely to be frail. But also you can have patients who exercise, quite vigorously up until their later life, and actually diagnosis or early treatment has stopped that, and therefore those effects that they were getting from that exercise start to diminish. But actually a lot of the elements of frailty that I'm interested in, particularly in function and nutrition as well, they can be modifiable, and I think that's kind of really important for my professional interest, is that we identify these things, but also we can try and put things in place to optimize people or help them recover. Yeah, so I think it's mainly functional and physical activity. And for us, you know, in my practice, some of that is looking at things quite objectively. Some of it is quite pragmatic, like when you call someone from the waiting room, how they get out of their chair, how they walk into the clinic, who they come with, how they look. And I think it is important then to have objective things alongside that, because often people put their their best foot forward when they're coming into clinic. You know, they've had help to maybe have a wash, get dressed, wear a good outfit, look quite sprightly when they come into clinic, but actually that might not be the reality of their day to day. And it's important to have those conversations, like Audrey said, to try and tease away, how someone is actually living their life on a day to day when they're not coming into clinic.
Interesting, the issue of, you know, how they walk from the waiting room, and we will discuss these indicators that we look in a refined way. But maybe, Emma, you have a different perspective because you're mainly focused on trying to include these patients in clinical trials. And actually, we know very well that clinical trials do have some stringent inclusion and exclusion criteria. And most of the time, frailty, comorbidities are actually exclusion criteria. So how do you handle this? Because at some point, I realized that maybe not all clinical trials do reflect the real world evidence or life, if you prefer to call it like this.
Yeah. So I think from our perspective, it's really important to have the rest of the MDT on board, because we see patients, we can either see them after they've been treated with, quite a few drugs, or they can come to us directly. So it depends on where they are in their journey as to when they're referred to us. But linking up with the MDT from an early stage, because we might not often be aware of sort of past issues, toxicities that have come about. So we need to get that robust history from the MDT and rely on them for, what has been in the past with regards to frailty. But obviously, we work quite systematically through a process to screen patients to go into a clinical trial. And it can often be that first visit that we pick up on that. I suppose we're kind of highly sensitive to it because we have to meet this criteria in such a strict way. So I think research nurses are kind of more proactive in identifying frailty in that respect.
Excellent. Thank you, Emma. So let's try to summarize again from your practice the frailty, let's say, indicators. Is it about weakness? Do you do any, we mentioned, walking from the waiting room, and there have been publications about the gait speed. And when we say patient have low physical activity, what does it mean? Because we don't have the same criteria. Even when you're healthy, your level of physical activity, if you ask me to walk 5 kilometers or 5 miles, this is a lot for me. But for someone else, maybe that's just very small. Audrey, what are your indicators in your practice? How do you pick the right, criteria?
Yeah, well, I think, as Orla said, that actually having some baseline and some background as to what the patient's previous physical ability was, and being able to assess that over their treatment period or their time with myeloma. But again, the physical aspects, how does your patient look when they come into clinic? Are they coming in a wheelchair now when they were previously walking into clinic? Are they having problems with their activities of daily living, which they weren't before, having to get help at home? Some patients will come to clinic and say, oh, my GP is organising for me to have carers into the house now. Well, that you know, rings bells, and you start asking questions. Well, why do you now need carers when you were independent before, and what has changed, and you know, what are the things that are driving these changes in your daily living habits. And yeah, just things like fatigue's difficult, because fatigue is inbuilt with myeloma and a lot of the treatments that we use. So patients are generally fatigued regardless of what their age or frailty at the start of treatment may be. But I think, you know, that kind of overriding tiredness and exhaustion, and just not being able to carry out their daily lives as they would normally do is extremely important, and something to certainly take heed of. Yeah, so just, you know, kind of general changes in people's lifestyle really is the most important thing.
Orla, do you have same opinion?
Yeah, I think so. I think when we think about the sort of phenotype of frailty that includes that low physical activity with low muscle mass and exhaustion or fatigue is in there, and I think Audrey raised a really important thing about the prevalence of fatigue within myeloma. We know it's the most problematic symptom for our patients kind of the whole way through, pre-diagnosis, after their initial treatment, but also into sort of later cycles of treatment as well. And it's a huge one, but it's really important that we remember that within cancer populations and within myeloma itself, fatigue and low physical activity are very closely related. And so often one drives the other as well. You know, there's disease-related fatigue and treatment-related fatigue, but we know that patients who have higher levels of physical activity generally have lower levels of fatigue. And part of that is also linked to muscle mass, because often what we see is this, what we call this cycle of this fatigue cycle within patients having cancer treatment, where they have fatigue or the presence of fatigue or something else that some other toxicities or symptoms that make them less active. That reduction of activity then drives some loss of function, loss of muscle mass, and then that further drives that sort of everything gets harder and more difficult, and therefore they have higher levels of fatigue. And we do know there's research that shows within cancer populations generally, but also within myeloma, that if we could intervene and support patients to regain some function, to become more active, and engage in definitely structured exercise, but at least increasing their general daily activity, that can help reduce that presence of fatigue. And I think that's what's really important in my opinion with frailty, and what we're probably not quite getting to in lots of places because of lots of barriers, time, how we assess these things, the people who are in our multidisciplinary team, the lack of services we discussed in our wider system for directing people to, and they all limit us probably really optimizing people the best that we could. And I think within myeloma, with more people living longer and reaching subsequent lines of therapy, I think it's really, really important that we start to rethink how do we intervene to either stop some of this in its tracks, or other most importantly as well, is how do we predict that this might happen and therefore prevent it happening in our patients that aren't yet frail but are quite highly likely to become frail. So I think we haven't got into objective assessment, yes, but I do think that there's lots of barriers to assessing frailty objectively, but I do think we need to start thinking about how we do that so that we can clearly signpost people onto the support that they might need to reverse some of these side effects.
Emma?
Yeah, so I was just going to bring in the importance here of real world evidence and observational type studies, and the benefit of nurses being involved in these types of programs, because very often, as we've mentioned before in our last session, that nurses have different, sorry, not just nurses, Orla, but we have different conversations with our patients than maybe their doctor does. So, and I think we can really drive this agenda by actually leading on these types of studies where we're getting more of this information around frailty, around, you know, day-to-day issues that will then inform our practice. So I think is a real biggie that we must start to look at a different way of how we do things, rather than sort of bolt something onto a bigger study. Maybe nurses taking the lead, or pharmacy physiotherapists taking the lead in these types of studies and programs, because I think it would be a benefit to our patient.
No, I
Yeah,
think
and
this is a reasonable proposal, Orla.
I agree with Emma, and I think often as well, you know, we know already there's a gold standard for measuring for assessing frailty, and that's to do comprehensive geriatric assessments. And often the big barriers to doing that are clinician time, or time within the team, and also that sort of lack of, or perceived lack of expertise. You know, that we can't maybe access a geriatrician for all of our patients, or we don't have everyone in the team. But I think it's important that we think of some of the screening tools that already exist that can be done in a quite timely manner, or even components of those, you know, components of a comprehensive geriatric assessment that many of us probably could do in clinic if we sort of rearrange how we do things, or just think cleverly about it. So for example, you know, the timed up and go is a test that you can do with patients, where you ask them to stand from a chair and walk 3 meters, come back and sit down, and there's cutoff scores for often a lot of these tests, where if someone gets below or above a certain number or score, that's an indication of risk, and therefore they're the people then you need to think, right, well, who do I refer them on to for a geriatric assessment, or they might need physio or whatever. And I think Emma raises a really good point, which is often we have the resource within trials to do these sorts of things that we, you know, could potentially get more of that data that we need. But often these patients who need this most are not in those trials. So that's one of the other challenges. And it is really important that we think about some real world data within our own services that we're picking up. And an example from our practice. So, you know, my clinical practice is actually mostly with transplant eligible patients. We run prehab and rehab during the stem cell transplant pathway at UCLH. But as an example of that, our last 12 months of data where we saw everybody who was coming for transplant, when we do a walk test with those patients, and we did a timed sit to stand test to look at their strength, and we compared them to what it should be for their age and what it would be expected for their age and their gender. And actually over 75% of those transplant eligible patients have indications of low functional capacity on those tests. So actually they come into clinic and they look really well, and they're fit to the sort of definition that we use when people walk into clinic, but actually they're probably at risk of functional decline quite quickly because of the level below what they're expected for their age and height. So yeah, I'm a physio running a physio-led service, and that's what we would look at. But it gives us a really strong indication that actually this isn't always about age, and it's not always about older patients. Actually, lots of patients who have comorbidities, who are on multiple medications, who've had a change in their circumstances, new diagnosis, new treatment, actually are likely to are increased risk of developing frailty regardless of their age.
So that brings me to a question to you, Emma, when it comes to including these patients in clinical trials. Assuming you have a patient who on paper, in theory, before you see the patient, would tick all the boxes of inclusion and exclusion criteria, but then you see the patient at time, you know, and then you would say, is there any indicator telling you, oh, I don't see this patient actually fit for this trial? Is it just pure clinical judgment, or just you get this by experience?
I think you do get, it's better when you are experienced and you've been embedded in it for a long time. That definitely does help. But it's the simple things, you know. Very often obviously we were a tertiary referral centre, so we have referrals from across Wales, and it can be just the issue of travelling, you know, someone who's more elderly. The trial might tick the boxes, as you said, but having them to come in for additional visits and travel sort of an hour and a half, 2 hours on a bus, you know, or in a taxi on their own, without that support can just be too much for them. So there's multiple factors around this. It's not just it's not something you can easily identify, but part of the screening process, I suppose why we have such a lengthy screening process for most myeloma trials, is that we are actually identifying like full system issues, and that we're doing that in a systematic way. Without that screening period and lead in, we could run into trouble. So I think it is very much catered for within the trials that we do for the patients. But yeah, I suppose I've been in research a long time, so I can identify those patients much easier than, someone who's been in since just, 6 months or so. So, yeah.
Definitely. Thank you very much. So let's move now to to discuss the impact of frailty on the choice of treatment. And here maybe my question to you, Audrey, how do you envision, or again, in your practice, how do you consider the importance of the dialogue between the patient, the doctors, but also the nursing staff? You are really on the front line and you see these patients. You spend more time with them compared to the doctors. And how is this helpful to adjust whatever given therapy?
I think it's really helpful, and I think, Emma made a few really interesting points about, it's not just always the physical capacity of the patient that is relevant when thinking about treatment for that patient, which is obviously what generally the doctors and the clinicians concentrate on, which is part of their job, is to look at blood results and patients' comorbidities and how they're going to fit into an actual treatment regime. But I suppose from a nurse's point of view, yes, we do spend a lot of time actually just talking to patients, not always about their myeloma, not always about their treatment, but just about general life, what their family support is, if they're lucky enough to have family or friends, relatives with them, then chatting with them as well, just to find out exactly what the patient's baseline is, and as treatment kind of goes on, how that changes, and if there's been any kind of subtle differences at home. And I think it certainly does have a big impact on how we would think about treatment options for patients. Things like travelling, as well, as Emma said. We in Glasgow, or certainly in the north of Glasgow, administer our parental treatment in one centre, which is at Beatson. However, we do have outreach centres across the north of Glasgow, where we have the option of maybe delivering a bit less intensive therapy, as in oral therapy alone to our patients. So, the frailty question does come into that. And actually, is this patient fit enough to be travelling long distances on public transport? For most of them, can they actually afford to make those journeys to a centre to receive certain types of treatment? So yeah, it does impact a bit on treatment options, but again, we don't have any robust ways of actually clarifying that, and clarifying frailty scores are very good, but again, as I said, putting them into practice is actually very difficult. And how do you then correlate a score with treatment options that are available for patients? So it is difficult, but I think being able to assess a patient and being able to have the experience to assess what their frailty may be going forward, and having that conversation with both the patient and their family is extremely important.
Thank you, Audrey. Orla, one question. Did it happen to you when seeing a patient that you went back to the doctor and say, oh, I think you have to modify the treatment. I don't know, the dosage of dexamethasone is very high, and this patient has lost a lot of muscles, or does it happen?
I mean, I think personally, not yeah. I think we can be included in the conversation. I don't think I've ever sort of been that direct in terms of thinking about being able to suggest there's direct links between certain things and others. But I certainly do think that certainly over the last year, where we've been doing more functional testing for our transplant patients, it's certainly been useful within our MDT discussions to say, you know, actually this person is this proportion or below their predicted scores, and they don't leave the house very often, and you know, all of the other things that come up in our assessments when we talk with patients. I do think it does make a valuable contribution to that whole team decision, decision making about treatments and things. And I think, you know, Audrey raises a really important thing around that conversation, and actually, you know, I think a lot of trying to assess and have tangible things about frailty is really important, so that we can bring that back to the patient and have that level of conversation with them, that they can then sort of engage in shared decision making about treatments. And travel's a huge one. Also, the other side is the sort of cognitive, both the cognitive ability to be able to follow instructions around taking medications, but also just the fatigue that can come with having to not travel just physically, but actually mentally and cognitively is also really, really important, and how all those things can have an impact and ultimately on people's quality of life. And I think having those conversations will then allow people to sort of make those decisions with their physicians a little bit easier, and really that's what we should be moving towards, being able to. I know it's hard because we don't necessarily use these tools, that we don't necessarily have the direct measures like Audrey mentioned, but actually being able to give an idea to people that, you know, today your journey was quite difficult. You said it was quite difficult. Actually, you might need to make that 10 times in the next however long. Just allows people to, you know, the doctors and patients to be able to make those decisions a bit more pragmatically and practically. And I think an important thing that's coming up to mind when we're talking about this is the notion of time toxicity as well. And that's really even more important to older patients. You know, actually, if we were able to explain to people that this is the proportion of time you will now spend in a clinic, or on a train to clinic, or in a hospital transport van, or in hospital itself, you know, versus how long we may think prognostically a person has, they're all really important things to be able to bring into these conversations. As well as that ability, how people's ability to manage with it. But I think it's also really important that we have to mention that this is dynamic, and so often treatment can actually help frailty, because some of the things that the disease burden might be, you know, limiting people to do can actually be relieved with some treatment, and therefore, you know, that ability to function and manage can actually change. And I think that's a really important thing for us to remember as well, because these things can get worse, but they can often get better, and we can intervene, as I've already mentioned. And I think that notion of it being dynamic, that it is hard, it can be not very tangible, but it is important that we're thinking about how it changes and how we can try to measure it better.
Thank you, Orla. One quick question to you from Otili Lakota, whether there are any available apps for smartphone or whatever tablets that patient can use at home to just guide them about the type of physical activity and some that they can do alone?
Yeah, I mean, that's a challenge. That's a hard one, because it is, there are lots of the patient support groups. I know Myeloma UK, for example, does have exercise leaflets, and also in the UK, Blood Cancer UK has advice on being physically active. So a lot of the patient charity or support groups often do have resources that patients can follow at a basic level. Obviously, people with specific bone disease and challenges may need that individualized approach to exercise safely. But when you mentioned apps, actually, what I was going to mention is so the clinical frailty scale, which is a based on the Rockwood Frailty scale that often many of us have heard of, there is actually an app for physicians or professionals to sort of help them screen their patients using that. So I have it on my phone, but I think it's just the CFS app, and it goes through questions for for you to follow, like an algorithm that will then help you to assess someone's sort of phenotype of frailty based on that scale. And that can be quite useful as a professional if you're not really sure whether you think someone's frail or not, or whether they're moderately frail or maybe they're at risk. That could be quite a good app to use to help you do that screen really quickly on your phone. And then off the back of that, you can then think about whether you need to assess someone further. But yeah, that's a really useful app for professionals.
Thank you very much for the advice. And here I'd like just to mention, I do apologize because we have also patient and families attending this webinar, and you have submitted a few specific cases about specific situations. Unfortunately, we cannot handle them, but I'm sure you can reach out by email to physicians or nurses where they can answer your specific concern. So let me jump to you, Emma, now regarding the role of the nurses in this specific population, especially when it comes to medication use, early and quick detection of side effects, and how do you manage, how do you orchestrate this in your practice?
Well, for us within research, it is one of the, safety is just the most important aspect of our role. And obviously we have standardized checklists to, when we see a patient, every trial visit, that we're asking those questions around adverse events, any hospital admissions. It's very strictly monitored within our setting, because obviously we need to report anything within strict guidelines to establish if any toxicities are related to the drug in any way. So it's really important for us, and I would say that that is one of the most important things for us to do. So we, it's kind of embedded in our practice, really.
Okay. One question to you, Audrey, and this is from Najia Gul, about what is, in your opinion, the major focus of managing frailty in multiple myeloma? If you have to identify, to make priorities, what would be your priority?
I think managing the frailties related to the patient's underlying issues, comorbidities, treatment toxicities, and then whether that then leads to, as Orla touched on, slight adjustments to treatment in order to be able to tackle those frailties. I think patients' social circumstances and how they're able to manage their daily lives at home is extremely important. So the emphasis is on physical activity, whether they're able to actually look after themselves, carry out their activities of daily living, and that would be getting up out of bed in the morning in a safe manner, because as we know, a lot of the myeloma drugs can be quite toxic, and patients can be quite at risk of getting out of bed and things in the morning, and that's a real concern for a lot of patients. Making sure that they're able to eat and drink well enough, that they're able to dress themselves, and if these things changed, as Orla touched on, it's a very dynamic assessment, really, Frailty, and it does change over time, and at some points patients may be better and managing better, and at other points are certainly more frail, and that changes as well with different drugs that they may be receiving to treat their myeloma. So I suppose it's been able to have an ongoing conversation and relationship with your patient, and knowing what their limits are as well, and being able to manage those, and signposting to other agencies and members of the MDT that would be able to help both within the clinical environment, as in the hospital or clinic that they're attending, and also in the community as well, involving general practitioners and social work, physiotherapy, signposting. A lot of our patients we signpost to our supportive services as well, which includes in the UK the Maggie's centres, which offer extremely valuable supportive services for patients, and these can be really helpful for maintaining physical activity and networking with other people in the same circumstances.
Thank you, Audrey. So let me focus a couple of minutes on nutrition and hydration. And first, a question to you, Orla. What kind of advice, because you see them, and I think there's probably a correlation between the physical activity, the physical capacities, but also the nutritional status of these patients. What kind of advice you would recommend? And I ask the same question to you, Emma, about the importance of hydration, because we know, especially that in myeloma, we know that there is a baseline kidney dysfunction, so it makes even things more complicated.
Yeah, nutrition is crucial, and again, one of those elements of the frailty phenotype is around unexpected weight loss, and often many of our patients, I suppose it's not unexpected weight loss, but often people experience significant weight loss during different treatments, and particularly after autologous stem cell transplant, and again, that just is an extra part of that frailty phenotype that our patients are really at risk of experiencing. And I think what is also interesting with our patients with myeloma is, there can be a tendency for patients to present with overweight and obesity in the first case. And so often they'll lose a significant amount of weight, but it might not be enough for people to really significantly worry about them. But actually it can be really significant for that patient, because often when patients have low nutrition and they lose a significant amount of weight, it's often muscle mass that they lose first. So you then end up, sort of precipitating into this low muscle mass state. So even though someone may still be within a normal BMI or a normal weight category, actually, if they've lost a significant amount of weight, that's a really, really important flag to refer someone for nutritional support, or at least assessment with dietetic colleagues, or nutritional input. Because you're right, it's very closely related to being physically active. If someone has no appetite, has no nutritional intake, has lost a lot of weight, it's very hard for that person to engage in physical activity and muscle strengthening exercises that they need in order to regain that muscle strength. So I think nutrition is crucially important. It's a really fine balance, and often patients present with nutritional problems sort of even before their diagnosis. So it is important to get those assessed if we can, and if you have the means to refer someone within your system.
Thank you, Orla. And as part of the new initiative we will be launching by the end of the month, the ICH for Patient, we will have, I think, a specific topic dedicated to nutritional supplements and the importance, and what is recommended, what is not recommended and useless. So we'll talk about this, but let me go back to you, Emma, and the importance of hydration.
Yeah, so I mean, it's crucial, and especially delving deeper into how much patients are drinking, because they could say, oh, I drink 8 cups of water a day, and then when you delve in deeper, they're actually drinking tea or coffee, which is obviously going to dehydrate them even more. So, and I would say from my experience, I've had a lot of sort of more frailer patients believe that actually is acceptable, that drinking lots of tea and coffee throughout the day is acceptable, and they feel that they are drinking the right amount. But it's the re-education around that actually that could be of detriment to you. So it's a real crucial part of frailty, because if patients present with kidney failure a lot of the time, and if they're not educated about these things, then they can quickly get into trouble, and their frailty can definitely be affected.
Thank you. Excellent. So for the last couple of minutes of this webinar, I would like to get your thoughts, so all three of you, about your ideal plan of care for frailty, or because I believe we discussed about medications, we discussed about physical activity, we discussed about hydration, nutrition, but actually it could be even more comprehensive, including the family support, the cognitive health, hygiene, just meal preparation, to allow these patients indeed to stay in good shape. So can you summarize for each of you in your practice, in your center, what do you think is missing, or what do you think you're doing very well, or something that needs improvement? The ideal program, you have to Bill Gates is offering you a big grant, and you want to write a frailty management and nursing program. Emma.
So for me, it would, from a research perspective, I think it would be ideal for every cohort of patients that we treat, not just myeloma, but every kind of patient that we treat, that there are a number of these real-world studies available as well. I think sometimes the importance of drug trials can obviously be prioritized for obvious reasons, but to coincide with that and to get the right outcomes for the patients, you need to have these real world evidence studies, and you need to look at different ways of providing them. They're not always easy to be bolted onto a study. We need to look at ways of innovative ways of delivering them. So I think every speciality should have a portfolio of real world studies that we can soon get these answers for these patients.
Excellent. Thank you very much. Audrey?
Hi. Yeah, I think in my own personal experience as a myeloma nurse, I've spent 6 years as a team of one. So it's actually, instinct, and my instinct of 30 years of nursing experience is extremely invaluable. However, I have struggled over the years to actually manage patients' frailty adequately, because we don't have a team behind us really. So I suppose I've been lucky enough we've now got a second clinical nurse specialist who's joined the team, which is why we're here today really, I suppose, getting a bit more of an interest in frailty and how that's going to affect our patients going forward, with the changes and advances in myeloma treatment now. But I suppose having a wider MDT and more presence at our clinics from physiotherapy, dietitians, occupational therapy, and all these supportive services that are extremely valuable in the patient's journey, which is now when I first started in haematology was probably 1 to 2 years after diagnosis, is now very, very much longer than that. So we're having to support patients for very much longer in their journey. And that does mean, that people get older and require input from other services much more in their treatment journey. So yes, just having that I suppose that hub and that team at clinic where people are on hand for help and advice when it's needed, rather than having to signpost to external agencies.
Thank you, Audrey. So Orla, you have the last word.
Yeah, I mean, I think I'm biased, but I think all of this comes back to we've lost having a rehabilitative approach within our health systems. I know particularly in the UK, it's so hard to help people access rehab. And actually, if we have good rehab across our cancer services, or if you're very lucky specifically within your tumor groups or within hematology, I think that would allow us to do really good frailty assessment. It would allow us to get people onto prehabilitation regimes as soon as we know they're coming, they're going to start a new treatment, to also rehab them after treatment, because again, we give people these great treatments that are going to prolong their progression-free survival, but actually what's the quality of people's survival? And that doesn't come down to drugs. That comes down to getting the right support and input with their nutrition, with their physical activity, with their function, with being able to get back to social activities that they might not be able to do. And my ideal service wouldn't be just a frailty service. It would be that rehab service that we have for everybody regardless of their need. But if we had that, then frailty would be managing frailty, or most components of frailty would be no trouble. So I think Audrey hits it on the head. It's that diversity of multidisciplinary team. Our patients have new needs now, and actually we need to start thinking that we don't necessarily think of the other professions that we need to start developing and including. We might not have them right now, but we need to be workforce planning to think about what does the hematology or myeloma service in 5 or 10 years time require. And I'm biased, but I think they require more allied health professionals, more embedded dietitians. We generally have good pharmacy input, but we need more of that sort of wider care team that can manage patients' holistic needs.
Wonderful. Thank you so much. Thank you, Emma, Audrey, and Orla, for this really great discussion. I have learned a lot from you, and congratulations for the great job you're doing for the benefit of patient. Definitely, we didn't solve all the problems, but already discussing some of these issues is a good start, actually, to try thinking about how we can move forward. And I believe this issue of frailty, aging, will not suddenly disappear. It will keep on increasing, actually. And this is something we need to be prepared to face in our routine and daily practice. This is why I'm very grateful to all of you. Thanks to our audience. Thanks to all those who posted questions and comments. Apologies for those where we couldn't take the questions, because time is always a matter of concern when you're doing this kind of webinars. But for the time being, I'd like to thank you all for being loyal, for following the ICH activities. And actually, if you're interested in nursing care with the new immunotherapies in myeloma, actually, we will have in a couple of days a special webinar in French as part of our regional activities, because we know it's also important, and there would be sometimes some language barriers also to provide this information in other languages other than English. So please stay tuned. This is the ICH across the globe and around the hematology field. Please stay safe and keep well. Thank you very much.